Hi, everybody. When Teresa called and asked me about speaking, it was probably last fall. And I said, yeah, put me down for telemedicine and telediagnosis, because at MICA, which is a medical professional liability insurance company, we insure physicians and advanced healthcare professionals for malpractice. We're going to have some cases. I know we are. I'm going to be able to tell you about actual cases that we're defending. Well, guess what? It's the second quarter of 2022, and MICA has not had any telemedicine cases filed in the last 2 years, and has only had a handful of diagnostic error cases filed in the last 2 years. It's not just a MICA thing. Your insurance company and MICA are they're members of the same association. And all of the companies put all their malpractice data into this one database. And so when I tell you about some MPL data in this presentation, it is MICA data, but also it's association data. So your insurance company has probably reported some of this. So you're also, in a sense, hearing from your own insurance company. None of the other carriers have had any telemedicine cases filed in the last 2 years. Well, we're stumped. We just don't understand what's going on, because if you are a patient and involved in telemedicine at the very beginning of the pandemic and you want to file a lawsuit, your statute of limitations is up now. In most states, it's 2 years. There can be some exceptions, but they're rare, unusual. So we don't know if perhaps the patients that were involved with telemedicine at the very beginning of the shutdowns still see you with the halo and appreciate what they say was your courage and your willingness to be available and try to take care of them at that time, and just not interested in suing you. I don't know if that will wear off and patients, as we get further into the year, will decide to sue. We're not sure. We're stumped, and the other carriers are stumped too. So I hate that I told Teresa I'll have cases to talk about, when in fact I brought you some diagnostic error cases, but they aren't telemedicine cases. This is my statement for CME purposes, explaining that I'm not covering any ineligible content, and I don't have any financial connections and haven't received any payments from an ineligible company. I am a lawyer, but I am not licensed in Utah, and I've never tried a case in Utah. But I have a staff of nurses and attorneys, and we answer Utah questions daily. And we also stay in touch with our Utah defense attorneys. As a matter of fact, I ate dinner with 3 of them last night, and covered with them what I was going to tell you today to make sure that I didn't step out of line. If you want true legal advice or true legal opinion, it's going to need to come from a licensed attorney here in Utah. And these are the learning objectives for today's presentation. And I don't think you would have achieved all that you have achieved if you didn't know how to read. So I know you know how, and I'm not going to read them to you. Despite the research and lawsuits, diagnostic error remains a problem. The father of diagnostic medicine is Dr. Mark Graber. Diagnostic error data and literature, Dr. Mark Graber suggests that while some types of errors can be significantly reduced, that diagnostic error probably cannot be eliminated. because of too many human factors being involved. Nevertheless, our dependence on safe medical care and also the potentially severe consequences for you if care is called unsafe mean that we need to continue studying diagnostic error and keep working towards managing the risk, because it is still showing up in lawsuits. Now, it's difficult to pinpoint the frequency of diagnostic error. Medical professional liability data only tells us about the errors that turn into claims or lawsuits. And that is an extremely small percentage of the millions of diagnoses made by physicians and advanced healthcare professionals every day, week, month, year in the United States. Most things don't turn into medical malpractice lawsuits. So we don't have a handle on the frequency. What I can tell you from a medical malpractice insurance standpoint is that diagnostic error drives overall about 30% of our claims and lawsuits. Diagnostic error was the primary allegation in 32% of over 21,000 closed claims analyzed by MICA and the association. So that overall 32% seems to hold strong. The association also reviewed pediatric claims originating in emergency departments and urgent care centers. They actually used physicians to review the case files. And so this was more like peer review. And they found diagnostic error was the most common chief medical factor in 40% of the cases. So I don't know if that says something about emergency department care, urgent care, center care, pediatric care, but the number went up some for those settings and for pediatricians. Also, in a study spanning 25 years, diagnostic error was the top allegation and the leading cause of claim-related death and disability. So it's still out there, we're still working on it. And I know you're anxious to hear some telemedicine related data. I just don't have it to give you. And I promise I'll share it when we get it and when the other carriers start to report it. Another reason that it's hard to report on the data is diagnostic error is difficult to define and track. There's not a universally accepted definition of diagnostic error among medical researchers, academic institutions, hospitals and health systems, even within physician practice groups. Errors may not be evident for weeks or even months. And it's often a subsequent treating physician that makes what some would say was the correct diagnosis or a different diagnosis. There's no claim or lawsuit, and the original physician who allegedly was erroneous in his diagnosis never hears about it. So it's hard to keep track of. Often it is a subsequent treating physician, a peer reviewer, or some other expert or researcher that finds there may have been a diagnostic error. And at least in medical malpractice lawsuits, autopsies are really rare. That is where you see a lot of confirmations of diagnoses or the identification of errors. But it's very rare to defend a case where there was an autopsy and to have that kind of information to present to a jury. There are different definitions of diagnostic error. I'm going to propose a definition from a medical malpractice standpoint, though. And after I tell you the definition, I'll explain why it works. I suggest that the definition is that a misdiagnosis, that a diagnostic error is a misdiagnosis, a wrong diagnosis, an incomplete diagnosis, or a delayed diagnosis, where a reasonable, prudent, similarly situated physician or advanced healthcare professional would have made a diagnosis, made the correct diagnosis, rendered a complete diagnosis, or made a quicker diagnosis. I generally find that physicians are hard on themselves and hard on each other. And many times we'll ask, Karen, why is the standard of care not black and white? Why doesn't my state law say the standard of care for pneumonia is to run these 3 tests, order this referral to this specific type of specialist, order this medicine dosage and frequency, and to follow up within this number of days? Well, doctor, that sounds like a clinical practice guideline. So it would be helpful to you that the standard of care reads like that. Yes, then I would know from a malpractice standpoint exactly what I need to do. It would probably be hard for your defense attorney to find expert witnesses to testify that they would have done exactly that same thing unless it was written into the law. So for one, we don't want to take away your ability to use your clinical judgment, your experience and training to decide what's best and what we're going to do for this patient. But unless it's literally written in the law, there's a variation in how you look at different conditions and how you treat them. And there might be several ways to do it, and they're all right. And if you leave the standard of care as what a reasonable, prudent physician would have done in a similar situation, it makes most of your care highly defensible and care that expert witnesses will support. Now, I'm not saying that flippantly. I don't mean that, yeah, you can just roughshod over things and prescribe whatever you want and you don't have to worry about the outcome because the standard of care will take care of it in the lawsuit. Because the physicians I've worked with for 26 years and know personally just don't do that. That's not who goes to medical school or who gets a master's degree or a doctorate degree. So that's not even an issue. But maybe you can see now why you kind of need, even in Utah, that definition of the standard of care to be a little more broad so that it encompasses almost anything you decided to do, and we can get experts to testify on your behalf. Who's at risk for diagnostic error? Between 2014 and 2018, only 2% of the lawsuits involved telehealth. Only 2% involved telemedicine. And the definition of telemedicine used in this research included telephone medicine. So knowing that, 2% is really low. And the medical specialties with the highest number of closed and paid telemedicine claims were family medicine, internal medicine subspecialties, internal medicine, and OBGYN surgery. The organizations updated the research and took a look at 2016 through 2018. The top primary allegation against family physicians was diagnostic error, and it was a little higher at 50%. And the top resulting medical conditions in those family medicine claims for diagnostic error were cardiac arrest, pulmonary embolism, lung cancer, cerebral infarction, and prostate cancer. Between 2016 and 2018, we also looked at internal medicine closed claims, and the top resulting medical conditions related to a diagnostic error were very similar. Cardiac arrest, lung cancer, and cerebral infarction were the top three. The top specialties by closed claim and diagnostic error were radiology, and radiology far and above the other specialties. Radiology, the American College of Radiologists, just like the American Society for Anesthesiology, put in some great quality improvement tactics and techniques. But radiologists are still involved in the most diagnostic errors. After that, and I mean very far below it, internal medicine, family medicine, OBGYN with surgery, the internal medicine subspecialties, and emergency medicine. So if you're trying to think, okay, am I a specialist or practice a kind of medicine and see patients most involved in diagnostic error lawsuits, I've just given you an idea of who and what they are. Most NBA fans, commentators, and writers choose a triumvirate of the elite players from their local NBA team and call them the Big Three. Being new to Arizona and Utah, I had to look up the Utah Jazz's Big Three. And right now, it looks to be Donovan Mitchell, Rudy Gobert, and Mike Conley Jr. An important diagnostic error study came out in 2019. Researchers at Johns Hopkins combed through 11,000 closed malpractice lawsuits. And again, it was physicians combing through them, but it was the actual case files for medical malpractice lawsuits. And they realized 3 types of conditions were responsible for 75% of the serious misdiagnosis-related harm. And those 3 types of conditions were vascular events, infections, and cancers. Within those 3 were 15 specific diseases, accounting for 47% of high severity misdiagnosis-related harm. And I've listed those for you. Again, just another idea, what's my specialty and what kinds of cases and patients am I taking care of compared to my risk for diagnostic error. Now, telediagnosis is brand new. And so it's a little like predicting the weather because there are so many variables involved in telediagnosis and then in whatever might be the resulting lawsuit. The evidence so far on the effectiveness of telediagnosis is pretty limited and mixed. Most patients and physicians tout the convenience of telemedicine, saving on mileage and parking and time to travel to and from the appointment. Patients seem especially appreciative, but we really need more data. We don't have enough yet to be able to say that that convenience also equals efficient telediagnoses. We also need some cases to look at. Another thing I want to bring up is the keen appreciation for the limits of telemedicine. Something constantly to be aware of. And I think this is how it'll play out in a medical malpractice lawsuit. If you're served with a lawsuit, your defense attorney is going to ask you for your CV. And even if your CV lists all these things, your defense attorney is going to ask you for any documentation that you can get your hands on, including your medical school transcript, evidence of your performance during your resident training, any continuing education credits you earned while you were a resident, any and all continuing education credits that you've earned while in private practice. And the majority of physicians practicing right now were educated and trained in a system that did not include telemedicine. And most likely, the folder you hand your defense attorneys will be devoid of anything telemedicine related. That's okay, we can work with that. But this is what the plaintiff attorney is going to do with that. The plaintiff attorney is going to look at all your credentials, experience, education, not see any telemedicine, and point out to the jury, doctor, so yeah, you've been in a practice a long time, but with telemedicine, you just thought, I'll adapt my traditional education, training, and experience to telemedicine. Doctor, would you want your mother to see a physician that hadn't had any formal telemedicine training? Is that who you would send your mother to? Now, I'm not expressing my own personal or professional thought on it. I just want you to know the plaintiff attorney is going to try to make it look like, despite your extremely busy schedules and the number of patients you're trying to see in a day and the number of patients who need you to see them that day, I know you don't have time for a lot of continuing ed, but that is how the plaintiff attorney is going to approach it, that you tried to do the bare minimum to engage patients in telemedicine. And in fact, all these CME courses were available. Look, here they were in your area, in your city, your county, online. These were free. These were at a minimal cost. And they're going to present all that to the jury. We can still defend good physicians who don't have that telemedicine training in their folder. But I recommend, even if you don't think that it's going to benefit you and the care you provide, go ahead and get some. Go ahead and get some continuing medical education on telediagnosis, telemedicine, so that you don't have to hand your attorney that empty file. So your attorney will be able to say, well, in fact, the doctor did recognize, hey, maybe I need to get a little more educated on telemedicine, and took these 3 courses. And that's going to go a long way with the jury, and especially with a jury in Utah who really takes their role in a lawsuit very seriously. They really do pay attention and try to apply the judge's instructions to the testimony and the other evidence they saw in the trial. You have good juries in Utah. I hope it stays that way. So again, appreciation for the limits, specialized training, these could be important in a lawsuit. Most of the allegations in the lawsuit are going to say that you did something negligently. And an example of an allegation related to telemedicine might be, Dr. So-and-so negligently chose a telehealth appointment over an in-person appointment. And what we're going to want to show the jury on your behalf is that your clinical judgment actually went into the choice of the appointment type, and that it wasn't just about convenience for you. I know that you don't have time to document every aspect about the patient that you clinically considered before you decided to say, let's see you by telemedicine or let's see you in person. You don't have enough time in the day to document that in every single record on every single patient. A way that you might still be able to show that your clinical judgment was part of that decision is developing a protocol for your office staff to use to help them decide, does this patient need a telemedicine appointment or does this patient need an in-person appointment? And that way, your defense attorney would be able to show the jury, Dr. Smith's office staff uses this protocol. Dr. Smith's clinical judgment is represented in every single aspect. And see, Dr. Smith even included that if they had any questions about the appointment type, they should talk with one of the advanced healthcare professionals or physicians in the practice. Clinical judgment for this particular patient, it's all in this protocol. Now, that may just be a stopgap measure, but it is a way to show that you were not careless, you were not negligent in choosing the appointment type. Some clinical judgment went into the choice of it. And I do have a draft protocol that you might be able to use or compare with the one that you're using and see if you want to add or change anything. Unfortunately, I've run out of business cards. And I don't know if you would want to write down my email address or after the presentation, let me write down yours. But I would love to share the protocol with you, and you don't need to be insured by MICA. And I'm not going to try to sell you insurance. I'm not a licensed insurance agent. I don't even know how to sell you insurance. And I'm also not in sales and marketing. I'm not trying to hard press you. I just really want you to have the information out of respect and concern, and the fact that the number of you seems to be getting smaller, but yet the number of us is getting bigger, and I want people to treat you well and for you to have what you need to practice. Anyway, so we talked about continuing medical education. Most physicians, probably my age and up, were educated and trained in a system that looked down on second opinions and consults. I have friends who are practicing physicians who have actually said they might even feel ashamed about getting a second opinion or consult. I also know from reviewing thousands of participating provider agreements that often there's no reimbursement or coverage for second opinions or consults, and it would most likely be something your patient would pay for out of pocket. But in talking with younger physicians, when I ask them about this, I'm hearing, yeah, I think second opinions and referrals are okay. I would appreciate the help. I don't know if the medical school education is different. I don't know if the graduate medical education training is different, if it's a cultural or a generational difference, but they seem open. And I don't know that it's the answer, but while telediagnosis is brand new, and you might be trying to make a diagnosis purely through telemedicine, maybe a second opinion or a consult wouldn't hurt, at least until we get some data and you're able to get some education under your belt and can definitely do this on your own. It's just a thought, just a thought. Also, having an actual checklist, maybe taking a timeout with the patient where you go over the checklist and you also give that patient a chance to tell you about anything they haven't told you about before, because we know you don't get all the story. Sometimes you never get all the story. This might prod them into providing that information, just as one more way to double check yourself on that diagnosis that you're trying to make purely through telemedicine. I do have some good news for you. 65% of malpractice claims and lawsuits are dropped, withdrawn, or dismissed. There is a tiny sliver that ever makes it in front of a jury. About 22% of the cases are settled, and it's just a tiny few that are tried in front of the jury. And usually a jury, 86% of the time, finds in favor of the defendant physician. I know sometimes it might feel like in the headlines that physicians are losing cases left and right, but they aren't. And especially in Utah with good laws and good juries in place. And not that I would ever want you to be sued, but it probably would have been a good time for a physician to be sued during 2020 when the Gallup polls showed physicians at an all-time high with the public's perception of very high honesty and ethical standards. Now, the courts were all shut down in 2020, and no lawsuits were being tried, so we didn't get to put that good news in action. But physicians are the gray line, and you're still at the top. And I want you to know this because I want you to know that if you are sued, when you walk into that courtroom, the jury already likes you. And it may not feel that way, but most jurors, even young jurors, still have high respect for your education and your experience, the amount and type of work you do. They've already put you on a pedestal before you walk in the door. It's a really good place to be. You may have been reading about large verdicts, and in the medical malpractice insurance world, we started calling these nuclear verdicts, and they're verdicts over $1 million. And we're not seeing very many of these in Utah. We're not seeing many in Arizona or Colorado. We do see them in Nevada. And it's a different world there from Utah. But lawsuits are down, jury verdicts are going up, and we can't blame everything on the pandemic. The record-setting jury verdicts occurred between 2015 and 2019, well before the pandemic. And most likely, it has to do with normalizing these large dollars to the American public by bombarding us with every headline about every verdict possible, so that we've seen $30 million verdict, $20 million verdict, even $230 million verdict. So many times we're numb to it. And there's a way that the plaintiff attorneys use that same technique in the lawsuit. They normalize that not large number for the jury. They begin the trial and they go ahead and state that the jury should find in favor of the plaintiff and should award $15 million. They go ahead and say it. And then throughout the trial, they say it again and again and again, in hopes that by the time the jury goes to the deliberation room, 15 million, sure, that doesn't sound that bad. I've heard it a million times. That's the hope. I did bring you some diagnostic error cases. Sorry, they're not telemedicine. If you invite me back next year or would rather have another speaker from my department next year, I really think we're going to have some telemedicine cases for you. These are some cases that we've recently closed. They're not terribly exciting, but actually most of the lawsuits against physicians and advanced healthcare professionals are not the huge, giant things you read about in the news. This first case was a failure to diagnose Lyme disease case, and the patient was the plaintiff. And in her lawsuit against the rheumatologist for failure to diagnose Lyme disease, she reported to her primary care physician body aches, joint and muscle pain, muscle tenderness, and headaches. Also fatigue. And this had been going on for more than a year. The patient then went to Texas and then had a tick bite and then had a rash form around the tick bite and stayed in Texas for several more weeks and came home. She goes back to her primary care physician, complains about the same things, body aches, joint and muscle pain, muscle tenderness, headaches. And the primary care physician tells her in documents, I'm thinking fibromyalgia, but I'm going to send you to a rheumatologist. She had one appointment with the rheumatologist. And both in the questionnaire she filled out about her medical history and in talking to the rheumatologist, never once did she ever mention there was a bite on her foot, the bite turned red, a rash formed around the bite, or that she'd been to Texas. She didn't check rashes on the form. She didn't check tick bite in the history section. The rheumatologist did a good physical exam, documented no evidence of joint inflammation, swelling, or rash. And the plaintiff, but the plaintiff did have muscle tenderness in various parts of the body and fatigue. The plaintiff did share that she had valley fever 14 years prior, and in an interview with him after the lawsuit was served, the rheumatologist said he was considering fibromyalgia or a recurrence of valley fever. He told her he wanted to run some labs and have her come back in 3 weeks. 3 weeks goes by, she hasn't gotten the Lyme disease test, and she reschedules her appointment. She reschedules her appointment again, and then finally gets to the lab to get the Lyme disease test done. And I'm letting you know this so you can see how many weeks have passed since her bite and the test. Because when the test comes back, it's negative. And she canceled and rescheduled and canceled and never went back. Now, it does turn out she's been treated by her primary care physician through all this. There wasn't any communication, though, between the rheumatologist and the primary care physician. She files a lawsuit and says the rheumatologist failed to diagnose Lyme disease. There was great expert witness support for the rheumatologist. Everyone agreed this was without merit. Although the plaintiff seemed to be moving forward, out of the blue, she files a motion to dismiss the case. No known knowledge of why. I don't know if she realized maybe she had made a mistake. I don't know. My thought about if this had been a telemedicine appointment is whether the visual, the camera, would have been capable of helping the rheumatologist really examine her skin and look for swelling. But it's hard to say. Well, and I gotta tell you, I talked to a lot of rheumatologists, and they almost all have told me that they continued to see their patients when they could through the shutdowns. They said they take measurements, and measure angles of things, and they have to feel the patient. They have to feel things. And they did not rapidly move into telemedicine. And with the return of inpatient appointments, in-person appointments, many of them have told me they've just dropped telemedicine pretty much altogether. They just don't feel like it works for them. Then I talked to psychiatrists, talked to a lot of them, and they immediately embraced telemedicine, and they say it's working well for their patients and their specialty. And now they're calling me with advice on, I'm not going to renew my lease. I'm going to sell the office building. I'm letting go of most of my staff. I'm going to be pure telemedicine. I don't need in-person appointments. It's very interesting to see how it panned out. Now, I would say most physicians I talk to in all the specialties have a hybrid approach. They're doing some things where they think it's appropriate by telemedicine and some things in person. But the rheumatologists really do seem to be fully back engaged in in-person care, and I don't know if that's what you guys are seeing. Now, something that might have nipped this claim in the bud is if this rheumatologist had had a tracking and follow-up system, not only for lab results and test results, but also missed appointments. Truly, from a risk management standpoint, this claim might not have been filed if the rheumatologist maybe had had someone from the practice call the patient, maybe twice. Telephone call to patient, explained or emphasized need to come in for appointment, rescheduled. Maybe done that a couple of times. Maybe even sent a letter. Dear Miss So-and-so, you've canceled appointments on these however many dates. My staff has tried rescheduling you. Please call our office as soon as possible to reschedule. I remain available for your care. That might have just kept a claim from even being filed, but we don't know. Maybe it wouldn't. A failure to diagnose pancreatic cancer case. The patient presented to the emergency department with complaints of abdominal pain. The ED physician's initial impression was appendicitis and ordered a CT of the abdomen and pelvis. The radiologist's impression was highly suspicious for appendicitis to be correlated with clinical and laboratory results. The radiologist noted in the report no intra or extrahepatic biliary ductal dilation in the gallbladder, no focal lesions on the spleen or liver. The pancreas did not contain any masses, and there were no signs of inflammatory changes or ductal dilations. 6 months later, the patient returns to the emergency department. A different emergency department physician examines him and orders another CT of the abdomen and pelvis, and a different radiologist reads it. This radiologist reported a large attenuated mass involving the pancreatic tail, concerning for pancreatic adenocarcinoma, and multiple lesions in the liver, adrenal gland, and spine. The patient died a month after that second CT. The patient's wife, minor children, and adult children were the plaintiffs. They sued that first radiologist, alleging failure to diagnose pancreatic cancer. Of course, the plaintiff's experts testified they saw an irregular lobulated mass compatible with pancreatic adenocarcinoma in the tail of the pancreas on the first CT. Unfortunately, the experts for the radiologist, but again, they've got a little hindsight bias here, said they saw what appeared to be a classic presentation of pancreatic adenocarcinoma encased in the splenic artery and surrounding fat in that first CT. The radiologist settled the case. And in a way, radiologists have always been practicing telemedicine. The majority of their information, patient information and visuals, have been electronic or online. and giant radiology practices have been reading films from foreign countries for 20 years. So I don't know that there would have been necessarily a telemedicine risk management aspect. And this is generally how the diagnostic error claims against radiologists play out, is that the experts generally see something on a second read. And even if you try to blind the experts, they still know you wouldn't be asking me to do this if there wasn't a problem. It's really tough on the radiologists. And I've got 1 more minute. I want to cover one more case with you. This patient was also the plaintiff, and she saw an OBGYN for a pap smear, which was positive for HPV and showed high-grade squamous intraepithelial lesions. The OBGYN notified the plaintiff of the result and later performed colposcopy and took biopsies at 3 o'clock and 7 o'clock. The path report came back, and the 3 o'clock biopsy was insufficient. The 7 o'clock biopsy was benign. This OBGYN reviewed the findings with the plaintiff and explained the need to repeat the procedure immediately after she delivered her baby. At this point, she's pregnant. After delivery, the patient did not return to see that OBGYN and presented instead to the defendant OBGYN in another practice in another part of town. She saw the defendant OBGYN's PA first and said she'd had chronic bleeding since the delivery. She reported a normal pap smear before the delivery. The PA did an exam, documented changes in the coloration of the cervix, the presence of blood, and that the cervix was rough to palpation. They did an office ultrasound. The PA showed it to and discussed it with the OBGYN, and they agreed on an initial impression of a possible prolapsing fibroid. The patient came back on follow-up and saw the defendant OBGYN for the appointment. She reported some improvement in the bleeding. The defendant OBGYN discussed a possible diagnosis, including subclinical infection or a prolapsed fibroid, and went over treatment options. The plaintiff agreed to antibiotic therapy and monitoring. 2 weeks later, the plaintiff sees the defendant, and the bleeding has not resolved. The defendant discussed hysteroscopy, D&C, resection of fibroids, or prescribing Megace. The defendant ended up prescribing Megace and scheduled the plaintiff for hysteroscopy and D&C in 2 months. The plaintiff then went to see yet another OBGYN in another practice, complained of continued bleeding. You know, when I was talking about sometimes the patients don't tell you everything, and that's not your fault. The third OBGYN recommended hysteroscopy and said, let's go ahead and schedule you. So they scheduled a date. Before that procedure, she's got heavy bleeding, dizziness, lightheadedness, and she goes to the emergency department. Hemoglobin and hematocrit were low. They gave her blood, and the on-call OBGYN explained he thought maybe there were retained products of conception and she needed a D&C. The plaintiff said, I want you to do it and take out my ovaries. So she's now with a fourth OBGYN who's not related to any of the others. And right before the procedure, he does a pelvic exam and palpates a mass on the cervix. He does a biopsy, and thinking that the mass was probably going to be cervical cancer, maybe a rare placental abnormality, He reviewed the plaintiff's labor and delivery and other records. No mention of a mass or an abnormal pap smear. And the biopsy results come back and he refers the patient to oncology. The plaintiff was diagnosed with hypermetabolic neoplasm of the cervix and enlarged metabolically active lymph nodes. Following radiation and chemotherapy, she files a lawsuit against the very first OBGYN who did the pap smear that was, I guess, inconclusive in one way and benign in another. And the defendant, Micah insured OBGYN, who was the second one she saw. The experts for the plaintiff criticized the defendant OBGYN for not performing pelvic exams at 2 of her office visits and for not obtaining the plaintiff's prior medical records, including the concerning pap smear result and the instructions by the first OBGYN to repeat this after the delivery of the baby. Review of prior records is actually a pretty big issue in medical malpractice lawsuits, and I don't know if anyone's ever shared that with you. And juries do not understand why a physician or an advanced healthcare professional wouldn't get those records and read them and take them into consideration. Sometimes expert witnesses are willing to testify. A reasonable, prudent physician wouldn't have gotten those records and reviewed them. I mean, sometimes that's what a reasonable, prudent physician wouldn't do. But in the majority of our cases, even the defense experts testify the standard of care. A reasonable, prudent physician would have gotten those records and read through them. And in this case, the experts were saying this GYN should have gotten the first GYN's records and lab results and pathology results, and should have known that this was something she needed to be on the lookout for. And that OBGYN did settle the case. The first OBGYN was not a MICA insured, and I don't have any information on what happened with her part of the case, but the MICA insured settled. And it's hard to see this as a telemedicine case because almost all the appointments involved an exam, a pelvic exam, and I don't know, you guys tell me, are we there yet with telemedicine? But a way to maybe have nipped this in the bud outside of telemedicine would have been to ask the patient to help the practice get those prior medical records and review them. So if you're interested in the telemedicine consent form that we've put together for Utah, I'm happy to share that with you. I'm also happy to share with you what we have in a draft protocol for choosing a telemedicine or an in-person appointment. I promise, I'm not going to sell you insurance, and I just want you to have the information. I'm out of cards, so I can either give you my email address, if that's more convenient, or I can write down yours. And I would not give your email addresses to our marketing department so that they would then send you MICA stuff. I'm just not going there. But my email address, if you want to write it down, is Everitt, Keveritt, at mica-insurance.com. And I don't have an assistant that reads my emails or filters them or scans them, and I don't have anyone answering my phone. If you call or email me, it's me. So I really appreciate you coming, and I hope you have a great rest of the conference. I really like Utah. I really like this society. I've been working with Teresa since I started with Micah 3 years ago, and I think this is a really good society. And I've worked with societies all over the United States. I have lots and lots of societies to compare you with. Of course. It's Kevee, V as in Victor, ERITT. KEVERITT at MICA-insurance.com. Bye-bye. Sure. Oh, of course. It's okay. I'm happy to answer or try. Actually, a lot. I don't have a percentage. I would say 75%. And we love, in my department, we always love interviewing those physicians in hopes that they'll share some of their techniques through the years that we can publish and pass on to the younger physicians. Although I find a lot of physicians are very modest and not looking for fanfare, and they see it as, oh, nobody wants to read that, when in fact the younger physicians tell us that is exactly what they want to read. It is. You know, we've seen in some states, I've seen some really poor medicine practiced by physicians with wonderful bedside manner, and there was not a claim or a suit. And they often tended to be, for example, in rural Missouri, in rural Arkansas, in rural areas. And a lot of those communities are just so happy to have a physician. They're not looking to sue doctors. But the bedside manner was so good, they felt, you know, this is my community and I want to keep it intact. But I would say 75% of physicians in their career with never a claim or a suit. Actually, I used to say that, but now the audiences are full of physicians and yeah. A lot of my jokes now are outdated. Oh, thank you. Sure, are outdated. You can't make some of those references anymore. Right, but we've also, you know, seen lawsuits where the medicine was good and the physician had poor bedside manner, and the patient sues anyway. So poor bedside manner is a huge driver. Even with good medicine, they're still angry and want to sue. And something I've noticed now here in both Arizona and Utah is people in Utah and Arizona know a lot more about filing medical board complaints. And they file a lot more complaints than lawsuits. I saw the reverse of that in most other states. And, but the statistics on those medical board complaints are really good for physicians. They rarely end up with any kind of, even a letter of reprimand. But with a lawsuit, the patient does have, or the plaintiff has a threshold that they've got to be able to prove and file. And when they file a medical board complaint, the board has to write down and open a file on pretty much any complaint that comes through the door. You don't have that kind of a filter. But yeah, a lot of people in Arizona and Utah know how the medical board works. It surprises me.